All right, so next we have history, always important when identifying precipitants and causes of acute decompensated heart failure. So important in patients who have known heart failure, kind of what's the precipitating cause. It's very important to evaluate new or changing ischemic symptoms, especially in patients with known ischemic cardiomyopathy. However, generally, the most common cause of acute decompensated heart failure is medication non-adherence, and that's around 40% of patients, or dietary non-adherence as well. Again, important to evaluate for new ischemia or infarction. Uncontrolled hypertension, another cause. Arrhythmia, especially in patients with uncontrolled atrial fibrillation. Medications that can precipitate heart failure that are class 3, like NSAIDs, steroids, calcium channel blockers, and of course acute infections, so patient presenting with a pneumonia, UTI, or upper respiratory infection. Pulmonary embolism, of course, important if there is no other immediate causes of acute decompensated heart failure and other clinical suspicions of PE. Toxin, of course, cocaine, an important one that's often missed, and alcohol use, new worsening valvular disease or myocarditis. So all of these are very important to evaluate in patients coming in with a newly decompensated heart failure. And whenever you're triaging patients with decompensated heart failure, always important to look at the last dry weight, the last ejection fraction, prior ischemic workup, prior TTE, and the cardiologist that they follow with in the outpatient setting, and see if they actually follow up, and important to evaluate for medical literacy and medication compliance, as well as optimizing social history and avoiding, of course, those class 3 medications like NSAIDs, steroids, calcium channel blockers. So next up, we're going to be talking about early or acute management of decompensated heart failure.